Hello, everyone. Once again, good evening to all of you. Warm welcome to day two of the scientific sessions of the Oral Cancer E-Conclave. I, on behalf of Sterling Cancer Hospital, Foundation for Head and Neck Oncology, and Innovative Cancer Care, thank all the participants who are here with us on different social media platform. I'm sure that we are going to learn a lot more new things on today's session because it is going to be very a great discussion with a lot of panelists here on board and elite doctors from across the country who have joined us to impart us grave knowledge about the subject. I once again thank all the partnering organizations and the representatives who are here with us today for real tirelessly working to make this event really successful. I thank all the chairperson speakers and panelists who have given us their valuable time on this Sunday, on this beautiful Sunday. For now, I'll quickly invite Dr. Vikas Goswami, who is moderator for the next scientific session, to kindly take the session ahead.
Thank you. After a lovely discussion by Dr. Anil D. Cruz, let's move to the last session. And to chair the session, we have Dr. Viral Patel. Dr. Viral Patel is a MDS. He is President Gujarat State Dental Council, and he's past President IDA Gujarat and President IDA Ahmedabad. And he's founder and MD Dental Implant Laser Cosmetic Center, Ahmedabad. Welcome, Dr. Patel. And may I have the opportunity to invite Dr. Somesh Chandra. Dr. Somesh Chandra will be talking about surgical tips and tricks, learnings from mistakes and failure. And Dr. Chandra needs no introduction. Sir is professor at Sir has been the director at Sterling Cancer Hospitals. He is professor at Gujarat Cancer and Research Institute for over 7 years as faculty. He is director of oncology at Kailash Cancer and Research Institute, Gorat, Vadodara, and member of executive committee of Indian Association of Surgical Oncology. And he has experience with over.
Can you just? I think we can just go ahead if Dr. Veera has to make a.
Sure, sir. So we'll be starting. Over to you, sir.
I think Anil has already given you all the tips, and I might just tell you about some of the trips which I have made while practicing the science of oncology. My education is continuing, and I listen very intently to everything that Anil says and all the panelists have been saying. And a fair bit of what I'm going to tell you now might appear as a repetition of what has already been discussed. But I guess the last word in oncology and oral cancer surgery and management has not been said. And I'll take this opportunity to raise a few more issues on the same points. So when we talk about tips and tricks, I think we talk about something aside from evidence-based medicine, apparently, because that's all well documented. But then all evidence-based medicine also leads to failures. And then we have to revise the kind of medicine that we are practicing. And we have to look back and see whether we have been making any mistakes. And that's how medicine-based evidence is generated. And this medicine, till the time it is tested in trials and approved by peers, remains just maybe a tip and a trick, and that's what I'm going to talk about. So what is a mistake? A mistake is an avoidable event, definitely, but a failure is definitely not always the result of a mistake. When you practice evidence-based medicine correctly, you would still end up with some failures. And I chose to divide this talk into issues which are oncological and surgical. And the main issues in oncology are recurrence, which apparently for a surgeon would result from an inadequate resection. And we heard a lot about how to do a good resection in early oral cancers. and how to avoid an inappropriate resection, which may not necessarily lead to an oncologic failure, but which may be a disaster for the patient anyway. While we achieve a good oncologic control, we might still end up with fair amount of immediate, intermediate, and permanent surgical sequelae and complications, which we would like to avoid. So like I said, while we practice evidence-based medicine, we do end up with failures, and then we need to create some new evidence. And the evidence, like we discussed in the last hour or so, was that we need to do a frozen section for all tumors, especially in the tongue. And apparently that should improve, we thought that would improve the local control rates and therefore the outcomes generally. So these are some of the common kind of tongue dissections you would do. The question in my mind was, when you can see a good mucosa all around and you are cutting well away from the tumor, measured, whatever it be, 8 millimeters, 1 millimeters, or 8 mm, 10 mm, or 15 mm. Under good vision, why do we need a frozen section? And if at all, is it for the mucosal margins? So these are the questions which came to my mind. Which are the margins you would like to see? If you look at Pankaj Chaturvedi's paper, they found that the margins which are positive on frozen section were most commonly the lateral and the posterior mucosal margins. So you know which side you need to focus on, and you might end up with frozen margins. But also that some aspects, the deeper aspects, are definitely not getting addressed as yet. One of that is the concept of the complete circumferential and deep margin, which probably is the more important margin and which is out of vision, which you have to rely totally upon your pre-operative assessment of the radiology and your intraoperative skills at palpating the tumor and understanding the anatomy of where to cut. And then there is the conceptual paradox of margin status versus margin distance. We've been talking about the final margin distance, how far the tumor was seen on pathology from the edges of the tumor. And this concept was well brought out by Hiroshi Akiyama when he was talking about esophageal cancers, which have a tendency for great submucosal spread. And what actually we were talking about was the distance away from the visible or palpable tumor that you want to place a cut so that you actually end up getting an acceptable margin. And how do you go about doing that in the deeper tissues? How do you ensure where exactly you make the cut? And if at all you end up with a positive or a closed margin, how do you deal with it? Do you deal with it intraoperatively? If yes, how do you do that? And having done that, how much difference does it make? So these were the questions while I was practicing so-called evidence-based medicine. And I was sending these margins for frozen section properly tagged, as some of the panelists also insisted upon. And the collaborative study, which Anil cited, has also said that frozen section definitely has a place in the practice of oral cancer surgery. But together with this, I was sending this for gross assessment of margins. And this was done by the pathologist. In fact, I brought up this issue during panel discussion, IFNOS 2012. And one of the panelists made a comment that you seem to have a very good relationship with pathologists, which again this panel brought out. That we discussed beforehand how we are going to assess the margins. The pathologists normally do a bread loafing of the specimen. And when they do a bread loafing of the specimen, they can tell you about which of the margins are the closest. And instead of assessing all the margins for frozen section, then you can assess the closest margin for frozen section. Of course, Pankaj again came out a year later with this prospective study, and which kind of confirmed that a gross examination of the margins could be as good as a frozen section, provided you have got a gross margin of 7 millimeters or more. And then this was followed up with more publications that gross assessment of the margins is good enough in many of these states, especially for tongue cancers. And a frozen section may not actually be cost beneficial, and many of the panelists also said that it may not be actually be available. So this is a good tip, especially for tongue cancers, which Ashok Shah, who was moderating that panel on oral cancer, said that, well, fair enough, a tongue is a solid organ like kidney, and if you practice this is good enough. So what this tells you that you actually need to have a good relationship with the pathologist, good communication, and if the pathologist actually reports during intra assessment that one of the margins is close or positive, then it is worthwhile going to the lab. I actually go to the lab. I operate on the first floor, and the pathologist is on the ground floor, and the consultant pathologist and I examine the specimen and try and figure out which of the margins on the patient was actually positive. There are various methods of assessing the tumor bed and relocating the positive site. But that procedure is not standardized, but it is definitely worthwhile trying to do this in association with the pathologist and develop a protocol. The Dutch group has a fairly useful method of doing it, where they have paired tags, and that makes it easy to do that. But what happens if you do get a positive report? When you convert an R1 to R0, is it that easy? How much more tissue do you remove? Can you remove it in one piece, or do you remove it piecemeal when you revise the margins? And there's so many questions. So at present, I would leave it at the point saying that having discussed with the pathologist and having tried to relocate the site of positive margins, revised it, I always try and put some metallic clips, titanium clips there. Not because the radiation oncologist does a boost to that area, but in case a recurrence comes up, I have the most likely site to look at in radiology in the follow-up of where exactly I'm looking for the tumor to be coming around. Moving on, a failure is usually the result of a mistake which is avoidable. So we talked about how to avoid that, but there is another concept of a positive margin in the neck. We talked about E&E, but a positive margin in the neck. A case in point. I'll come to this. So this is a patient with a T2 buccal mucosa and this kind of node. Now, normally you would raise subplatysmal flaps, which in this case, if you do that, you would end up with a positive margin in the neck. Many times I get these inked. I ask the pathologist to ink the specimens and see if there is tumor at the surface. This is supported by this publication and many others initially. I think it's not a very new concept. Neck dissections are not typically margin surgeries, but it does increase the risk of local recurrent disease and for additional radiotherapy for that site. In the literature, those additional radiotherapy sites were possibly over the carotids or some other sites in the neck, which could be tagged with a metallic clip. But then the concept of a margin positive on the flat side is probably not made out very well in the published literature. And this paper also, this is from 2020 FD, also suggests that you should think about inking of the neck specimens when you are doing it for gross extranodal disease. And that's how I would do that. I would take out the subcutaneous fat here to cover that extranodal spread, which involves the platysma. And that's how you avoid getting a positive margin in the neck. But then we know that even if you do have the best practices, you still end up with failures. And then to find a way out, we must analyze it. So a recurrence is not always maybe a wrong surgery. And we looked at some of the recurrences, about close to 150 recurrences, and subjected. This was done as a graduate thesis with Bits Pilani, and based data mining technique was used. It's a good technique to use for small data sets. And we found that isolated neck recurrences had a different pattern from intraoral recurrences. They occurred much earlier. They were more reflective of recurrences of the original tumor. While many of the intraoral recurrences occurred much later, more than 3 or 4 years after the primary treatment, and possibly reflected second primary and second field tumors. When it's clearly on a different subsite in the oral cavity, and distributed in time, that's a second primary tumor. But when it occurs close to the primary site, the original primary site, many of them would be called a second field tumor. In course of the study, we found that these are the 8 points which we studied as a risk factor for predicting oral recurrence of oral cancers. And we found that oral hygiene and poor oral hygiene and restricted mouth opening were as strong predictors of recurrence as PNI or the histopathological differentiation or T or N stage. A case in point, this patient, you can see, can you see that picture there? I'll just move it. If you see this picture, this is a patient operated for oral tongue cancer, reconstructed with a radial flap. And the recurrent erythroleukoplakia occurs not in the residual tongue, but on the flap. So this is migratory mucosa from the surrounding sites. And this is a classic case of the kind of second field tumors that we tend to see in our practice. And this is the kind of thing you would see. The tumor sometimes may not be very, very apparent. And even the mucosa all around doesn't look healthy. So what I have started doing is that even for small tumors in the buccal mucosa, I tend to take out the entire buccal mucosa on that side, which to Anil may sound preposterous as a proposition. But then we have good reason to believe that this mucosa, which harbors a pre-malignant condition, an oral condition of malignant potential, ultimately leads to failure 4 or 5 years down the line. And for a patient, even a new tumor is just a cancer recurrence. And if it occurs on the same site where we've already radiated and done a neck dissection, it becomes so much more difficult. It's better to take that out as a kind of a risk-reducing surgery for these patients. And of course, not studying failures is possibly the biggest mistakes. So we looked at our own surgical failures, not oncology, we talked about that. And we did an audit of Clavin Dindo 3B, that's a kind of complication you have when you have to do a kind of intervention again after surgery. And we found that the overall rate of repeat surgical intervention was just 2.3%. But if of all the procedures, the head and neck and non-head and neck combined, but and 43% of all the surgical procedures were head and neck procedures. But 4 to 5% of oral surgeries and 4% of all head and neck surgeries actually accounted for. So that it was double compared to the other non-head and neck procedures, which was a kind of a surprise for us. And we found that 72% of these complications occurred after oral cancer surgeries, and only 25% after non-head and neck surgeries. And most of them were related to free microvascular flap reconstructions. Majority of these failures in free flap reconstructions were due to a hematoma, and almost all of them with a hematoma were given low molecular weight dextran in addition to a low molecular weight heparin, which was the practice of one of the plastic surgeons who was not ready to give it up. But having done this audit and looked at our own results, we could convince our colleague to give up the use of dextran. The hematoma rate fell, and our flap re-exploration rate and flap success rates have improved. But then when we try to avoid a failure, we might end up with another failure. When I was at the Cancer Institute, we had looked at consecutive mandibulectomies to see the patterns of mandibular invasion. And to our horror, we found that 25% of segmental mandibulectomies were for T1 buccal cancers. Looking back into it, we found that it is possibly because they were all posteriorly located in the sulcus, and it's difficult to remove these tumors without removing the mandible. Of course, marginal mandibulectomy at that time was just getting into practice, and all the consultants were not very comfortable doing it. But then what kind of marginal mandibulectomy do you do for this? So if you do horizontal marginal mandibulectomy, the deepest part of the tumor may be closer than you would like it to be. And we thought that outer table mandibulectomy could be a better option. But when we tried to do that, we started getting a lot of possibly the rate of osteoradionecrosis was double, because many of these patients were also radiated post-operatively. They were N1. So we modified our technique. We take care that we preserve enough paramandibular soft tissues and preserve the periosteum up to the point of care. We still remove more of the outer table, and we like to. You see, this is a small tumor here with no mandibular invasion, and we still do it. I personally prefer to do it as an arm lock procedure. Dr. Alok Thakkar has a paper on the incidence of positive facial nodes. And I think this is more on lines of the concept of a compartmental section as we practice for ITF and for tongue tumors. I think this should also be practiced for alveobuccal cancers, which go down, not up into the ITF, but grow outwards into the cheek and towards the paramandibular soft tissues. Having said that, done all the right surgeries and all the right oncology precautions, you might still end up doing a lot of harm to the patient. So this young man, he was punished by getting who was a tobacco chewer. He had his punishment when he got an oral cancer. But then the treatment was even harsher on him. And this is what happened ultimately to this guy. It's difficult for him to go out into society. So we have saved his life, but we have not saved his face. So we need something to do which is life-saving and face-saving. And as surgeons, the way we make the cuts actually make all the difference. And this is a famous quote: "Pray before surgery, but remember, God will not alter a faulty incision." So this you can see that this is from a textbook, and there's a label there which says that this is the classic cheek flap approach which we are talking about. But then if the tumor is here and you raise this flap here, you create so much of scarring here for no good reason. Wherever you operate, you are going to end up with a scar. So if the tumor is here, and why split? I mean, the most sacrosanct area in the oral cavity for function, I believe, is this 1 million and the commissure. So you need to protect this at all times. And so we thought that if we have this facelift approach combined with a single horizontal neck incision, which has been the current practice for some time, we might do a better job. And this is the result that's how it looks for most of the patients. And we have now a fair number of patients over the last more than 10 years. These are all patients who had segmental mandibulectomies reconstructed with fibula flap, or I remember this guy who had the entire right cheek, the labial mucosa, and the left cheek mucosa, and central arch mandibulectomies, and not doing a lip split either in the middle or at the angle definitely helps. You have to make sure that in the cases where you need not remove the soft tissues in the paramandibular area, you carefully protect the marginal mandibular nerve. The rest of the deeper third dimension of the tumor is well taken care of when you raise this flap from below and with intraoral cuts. This gives you a good exposure even with in patients with a restricted mouth opening. Of course, if you do that, the radiation can still have its own effects, but then you have done your part, and the patient does his own and is happy with whatever he gets. So to end up, tips are very simple. You must always think why, with what objective you are trying to do anything. What are the methods? What are the ways in which you can achieve that objective? You must have a plan on how to do that, and that plan may need to be revised every now and then, depending upon what kind of success you have with your earlier plans. And you must always share your results with your peers and publish them. Tricks, well, there are no tricks. You have to trick into your trick. The trick is in your mind, that you have to think that you are only as good as the results of your patients are, and each and every one of your patients actually deserves the best. And if you get the best results, you are possibly the best doctor in the world. Thank you.
Thank you, Dr. Somesh. So, any questions for Dr. Somesh from the panelists or audience? If there are none, may I request Dr. Patel to give the concluding remarks?
Good evening, everyone. First of all, thanks for inviting me to chair a session with experts of your onco field. I would like to emphasize just on one important point as a dentist, that functional rehabilitation should be as important as to control the morbidity and mortality. And excellent presentation, all the speakers, and special thanks to Dr. Somesh sir for inviting me here. And thanks, and wish you a successful future modules of this conclave. Thank you very much.
Thank you, Dr. Patel. Over to the organizers, please.